My name's Katie. I'm one of the fifth years currently at Liverpool. So I've done my final exams and I'm just going to be covering some of the main obstetric emergencies today. So in terms of topics that I'm going to cover, I'm going to start off just by talking about pre-eclampsia and how this can lead to some of the emergencies such as HELLP syndrome and eclampsia. I'm then going to talk about some of the things that happen a bit later on in pregnancy, such as antepartum hemorrhage, and then move into some of the obstetric emergencies of labour and after labour, so shoulder dystocia, umbilical cord prolapse, amniotic fluid embolism, uterine rupture, and postpartum hemorrhage. So I'm going to start off with an MCQ, so there should be a poll that appears. So it's just to kind of see what your knowledge is like before we start the talk. So which one of the following patients would meet the diagnostic criteria for pre-eclampsia? So there's 4 options, and if you all answer on the poll, and then we can discuss the answer after. So I'll let you read the options yourself and answer. So I'll just give you a bit more time until a couple more people have answered, and then I'll end it and we'll go through the answers. So I'm going to end it there because most of you have voted. So I'll share the results with you guys. So as you can see, most of you have gone for E, a couple of people for D and C. So let's just close that down. So the correct answer is in fact E. So in terms of preeclampsia, it's a lady, so the answer is E. So the reason it is because it's over 20 weeks. So that's really important in that you can't diagnose them with preeclampsia until they're past the 20-week gestation point. A raised blood pressure over 140/90 on 2 occasions measured 4 hours apart. And then the next bit is in the presence of 300 milligrams protein in a 24-hour collection of urine, and they've got to be previously normotensive. So I'm now going to move on to talk about this. So as the talk goes on, you'll understand why some of the other questions weren't quite right. So generally hypertension in pregnancy. So 1 in 10 women will have at least 1 episode of increased blood pressure prior to the delivery of their baby. So this is quite common, but only 3% of pregnant women will develop preeclampsia. And it is unfortunately a leading cause of maternal death. There's a clear classification system for hypertension in pregnancy, and this is probably really quite important to know for finals. So first and foremost, starting off with chronic hypertension. So this is a lady who has a blood pressure over 140/90 on 2 occasions 4 hours apart. And this is detected in pregnancy less than 20 weeks gestation. And what this ultimately means is this lady's probably got essential hypertension, but this hasn't been picked up until she's come and presented pregnant, because often women of childbearing age won't have a regular blood pressure monitoring, so they might not be aware of this. And there's an increase in the number of women more recently who have got chronic hypertension. And this is worrying, as it's an increased risk for like mum and baby, and an increased risk of things like preeclampsia. So the next classification is non-proteinuria pregnancy-induced hypertension, which is probably more commonly known as gestational hypertension. And this is where a lady has a blood pressure over 140/90 on 2 occasions, at least 4 hours apart. And this is after the 20-week mark. And this is in a previously normotensive patient without the presence of proteinuria. And these patients are often really asymptomatic. They need to be monitored really closely and have regular urinalysis to check that they don't develop protein and therefore develop preeclampsia. But in terms of management, these patients are often managed with lifestyle modifications or, if severe, some oral antihypertensive agents. And in pregnancy, these tend to be things like labetalol is given first line in this country, but you can also give nifedipine or methyl-dopa. And then the final one is preeclampsia. So this is where the blood pressure is over 140/90 on 2 occasions, at least 4 hours apart during pregnancy. And this is in the presence of at least 300 milligrams of protein in a 24-hour collection of urine. So this must arise after the 20th week of pregnancy in a previously normotensive woman and will typically resolve completely by the 6th week postpartum. Okay, so a little bit more about preeclampsia. So there's lots of different risk factors for developing preeclampsia. So these are often things like it being the first pregnancy, any lady who's had previous preeclampsia in a pregnancy, or if there's been more than 10 years since her last baby. Any woman who's aged over 40, increase in maternal age often is a risk factor for a lot of complications in pregnancy. BMI of 35 or more, a family history of preeclampsia, and that's often, especially if your mother had preeclampsia with you as a baby, then you're much more likely to develop it when you become pregnant. And then going back to this chronic hypertension, so any lady that has a bucking diastolic blood pressure over 80 is at increased risk of preeclampsia. And then other things like multiple pregnancy and renal disease. So you might think, why is it really important to know these? And I think the most important reason that you need to be aware of these risk factors is because we can prevent or help to prevent preeclampsia. And this is with low dose aspirin. So when a woman presents to her booking visit, they will assess risk for preeclampsia. And if she's deemed to be high risk, then low dose aspirin can be given from 12 weeks and it needs to be taken until delivery of the baby. So in terms of symptoms, the classical textbook symptoms that you probably should know for exams include frontal headache, visual disturbance and epigastric pain. And then in severe cases, you'll often see in textbooks things like edema of the face and hands, hyperreflexia and clonus. But I think it's important to know these classical symptoms, but realistically, most women are asymptomatic and some may have some vague flu-like symptoms. And this just highlights that any time a pregnant woman presents to you as a medical practitioner, no matter in what sense, you always need to be thinking, could they have preeclampsia? You know, regularly checking their blood pressure and urinalysis. So in terms of the management then, there's no cure for preeclampsia other than delivery of baby and placenta. So most women who get diagnosed with preeclampsia will need hospital admission. A lot of the time we'll just give oral antihypertensives. So like I mentioned before, labetalol's first line, but you can give nifedipine and methyl-dopa. You need to monitor their FBC, UNE and LFT, and that's to look out for the complication of HELLP syndrome, which I'll talk about in a second. Serial ultrasound assessment of the fetus, amniotic fluid volume and maternal and fetal Dopplers. And this is to check on the fetus. CTG will be used, and that's to look for any signs of fetal distress. And then postpartum fluid management. So at the minute, the UK guidance suggests fluid restriction of about 80 mils an hour. And the complications that are the real obstetric emergencies are HELLP syndrome and eclampsia. So moving on to HELLP syndrome. This is a really severe form of preeclampsia and is characterized by hemolysis, elevated liver enzymes and low platelets. So the name itself will help you kind of remember what's in it and what characterizes it. So this usually occurs between 27 and 37 weeks gestation and will cause progressive and sometimes quite rapid maternal and fetal deterioration. And that's why any lady with preeclampsia, you must do them FBCs, check their liver enzymes, because you really don't want to miss this. So in terms of the management, even if you suspect this, before you get your blood test results back, you need to start management. So you'd give a continuous IV infusion of magnesium sulfate even before you get the blood test results back if you really do suspect it. And that's just a seizure prevention. Then in terms of antihypertensives, as this is more severe than just preeclampsia alone, we look at intravenous agents. So you can give labetalol intravenously. And then you want to deliver this baby. The baby needs delivering. So you'll often use intravenous dex. And that's not only to help the baby's lung maturation, but it also actually reduces the postpartum complications in the mother. You can consider a platelet transfusion and fresh frozen plasma, depending on how severe the lady is. But this is really important to note that if you suspect someone has HELLP syndrome, attempts to delay the delivery to help with fetal maturation and to help the steroids have the full effect on the lungs are absolutely not recommended. And if someone has HELLP syndrome, you need to deliver the baby straight away. Thankfully, most women do recover from the syndrome, but in women that don't, stroke is the most common cause of death. And now eclampsia. So this is defined as the presence of tonic-clonic convulsions and or coma in a woman with preeclampsia and in the absence of any other identifiable cause or neurological conditions. So the drug of choice is the same as in HELLP syndrome, so it's IV magnesium sulfate, and this has been shown to reduce the incidence of further convulsions. Iatrogenic premature delivery of the fetus is required, and prior to 34 weeks gestation, again, you should be given steroids to help reduce the chance of neonatal respiratory distress syndrome, but you shouldn't delay delivery for them to have their full effect. And unfortunately, eclampsia is associated with significant maternal morbidity, and in particular, this is cerebrovascular events. So like with the HELLP syndrome, things like stroke due to this uncontrolled systolic blood pressure. So these patients are also at really high risk of thromboembolic events, and for that, they should be given some subcut heparin and TED stockings. And another point with the preeclampsia patients and the eclampsia patients is that if this lady is in spontaneous labour already at this point, and you think it would be quicker to deliver the baby vaginally than by C-section, you should still give an epidural. And even you might think, oh, well, there's no point because it won't help with the pain management because there's not enough time. It really, really helps lower and control systolic blood pressure. So even if you're delivering this baby vaginally, an epidural will really help. Okay, so we're going to move on from the hypertension in pregnancy and look at some of the causes of antepartum hemorrhage. So there's another MCQ. So I'll read out the question. So a pregnant lady at 36 weeks gestation presents to the emergency department complaining of a 4-hour history of severe abdominal pain and reports having noticed reduced fetal movements. She's not noticed any PV bleeding. Oh, I think the answer's come up already. Sorry about that. She's not noticed any PV bleeding. They're her vital signs, and she's got this tense woody uterus. So you've probably already seen the answer, but we'll talk through it anyway. So I'm going to end the poll there. Okay. So the answer in this case is placental abruption. So this lady isn't actually bleeding, but she's got this severe abdominal pain, and really importantly, her examination findings are a tense woody uterus. And this is, I will talk about it, but this is an exam buzzword. So anyone who has a tense woody uterus has placental abruption. But I will talk about the other ones and you'll understand why it's not that any of them. So antepartum hemorrhage is defined as any vaginal bleeding that occurs after 20 weeks gestation. And it complicates about 5% of pregnancies. But most of these will be relatively small amounts of blood loss, and a lot of them are okay to be managed, assessed in hospital and sent home, but some are more serious. And significant blood loss does pose a risk of mortality and morbidity to both mother and baby. So there's a couple of different causes. So it can either be caused by the placenta, caused by the fetus, or caused by the mother. So in terms of the placental causes, there's placental abruption and placenta praevia, which are two really important things for you to understand, and I'll talk about them more in a second. Fetal causes are vasopraevia, which is really quite rare, so I will touch on it slightly, but it's not something I think you need to know in depth for your finals. And then the maternal causes, I'm not going to cover them in this talk because none of them really are obstetric emergencies, but it's just things like vaginal trauma, cervical ectropion, carcinomas and infections. So how would you investigate a lady? So say a lady comes and presents to A&E, she's over 20 weeks pregnant and she's complaining of bleeding. So what are you going to do? So you want to take a history from this lady. So how much blood? How many times is she having to change a pad? Like, is she flooding? Were there any triggering factors? So has she had any trauma? Has she had recent sexual intercourse? Anything like that? Is it associated with pain? So to try and determine the cause, there's painful and painless bleeding. So that's really important. And then, is the baby moving? So has she noticed fetal movements, and have these been normal for herself? So then examination, you'd want to do a full set of vital signs, but most importantly, you want to know her pulse. Is she tachycardic? Her blood pressure, is it really, really low? Is it in her boots? Are you worried? In terms of bimanual examination, so you want to know, is the uterus soft or is it firm? CTG on the fetus will tell you if there's any signs of fetal distress. Then in terms of speculum examination, this is really important if you're thinking it's going to be a maternal cause. So you need to visualize the uterus, is there an ectropion? Is there any obvious trauma to the vagina? If you're thinking one of the placental causes, this is probably not something that you're going to do immediately. And then investigations, if this blood loss is significant, an FBC, is this lady anemic and clotting? And obviously if the bleeding is severe, you're going to cross-match her to prepare for transfusions. So placental abruption. So this is defined as the premature separation of a normally located placenta from the uterine wall. And this occurs before delivery of the fetus. And abruption may be revealed where blood escapes through the vagina, or concealed where the bleeding occurs behind the placenta and there's no evidence of bleeding from the vagina. And I think this is a really important concept to understand. So if you have a look at the picture, you can see in the first half of it, the placenta has separated away from the uterus at its edge. And that means the blood that's being lost from that separation is coming out through the cervical os, and the woman will present with vaginal bleeding. However, if you look at the second part of the picture, you can see that the placenta has separated away from the uterus in the middle of it. And that means as it's attached on either side, that blood can't leave and is trapped in that space. And as you can see, there's actually more blood with that concealed abruption than there is with that revealed one. And women often will present slightly later because they haven't got that PV bleeding, which is often very alarming. So risk factors include smoking, chronic hypertension, pre-eclampsia, and cocaine use. And then clinical presentation. So maternal signs and symptoms include kind of vaginal bleeding, but like we've spoken about, that might not actually be the case. Abdominal pain is really important. This is painful, so they will have pain. Sweating, they might be shocked, hypotensive, tachycardic, and they will probably have noticed reduced fetal movements. The CTG will probably reveal fetal distress. And then, again, this is all in capitals because the degree of blood loss does not correlate with the degree of abruption. So just because she's only lost a tiny amount of blood or no blood at all doesn't mean that she has not got a massive, massive bleed. It could just be concealed. And on examination, like I said before, the exam buzzword, these patients will have a woody uterus. I don't quite understand what it means by that, but it's tense, it's hard, and in an exam, they will say they had a woody uterus and it will be painful on palpation. And I think when I was on my women's placement in 3rd year, I didn't quite understand how much an emergency placental abruption was. And I saw a young lady, unfortunately, being brought in by ambulance who'd had a placental abruption. And she had massive hemorrhage, and she was very, very unwell herself, and she did lose the baby. And I think it brought it home how serious this is, and how, you know, even being brought in by emergency ambulance and rushed to the right place often isn't enough. So management. So stabilisation and monitoring, so A to E assessment. Anybody who comes in critically unwell needs an A to E assessment. IV access, bloods, and just monitoring these people. You know, even if when they present they're not tachycardic and the blood pressure's fine, it's monitoring it and making sure that it's not going in the wrong direction. You need to see the trend of it. Continuous fetal monitoring, because it can quickly go downhill. The fetus can be fine and can quickly be showing signs of distress. You need to give blood or blood product replacement if she's losing blood. Giving fluids is just not adequate anymore. You need to replace blood with blood. And you can look for ultrasound evidence of abruption, but often in these cases in severe hemorrhage, you haven't got time to be investigating it. It will be an abruption. So if the fetus is over 34 weeks, you should immediately deliver the baby via C-section. And if there's no fetal or maternal compromise, you can continue to immediate vaginal delivery, but I think the majority of them are delivered via C-section. If the fetus is less than 34 weeks, if the mother's unstable or are there any signs whatsoever the fetus is distressed, you must deliver the baby immediately. If not, you can manage these patients more conservatively. If they've had a really small abruption that's revealed, you know, you can scan them and show that the bleeding stopped, or it's very small amounts. You can manage more conservatively with the aim of delivering a more mature fetus. But if you're in any doubt whatsoever, then you would just deliver the baby. And unfortunately, fetal death is common in these circumstances. And if more than 50% of the placenta is separated, then it is a very common outcome for these babies. So one of the other placental causes of bleeding of an antepartum hemorrhage is placenta praevia. And this occurs when the placenta is implanted over the lower segment of the uterus, and it's potentially overlying the cervical os. And it can be classified according to the proximity to the placenta, to the internal os of the cervix. So it can be complete or partial, depends on how much of the os is covered. In this picture, it just shows you quite nicely the normal location of the placenta should be well away from the cervical os. And then in a placenta praevia, the placenta is covering that internal os. It's important to note that a lot of women on their 20-week scan will have a low-lying placenta, and the majority of them cases don't actually turn into a placenta praevia, and these ladies are rescanned often around 30, 36, between 30 and 36 weeks to check that placenta is no longer low-lying, and if at that point it's still there, then it will be classed as a placenta praevia. So the risk factors include multiple gestation, previous C-section, any uterine structural abnormality that might prevent the placenta from implanting where it normally would, assisted conception, and then, like I mentioned, this low-lying placenta at a 20-week anomaly scan. So clinical presentation, these patients present with intermittent, painless vaginal bleeding, which will increase in frequency and intensity over several weeks. So this is a really important thing to distinguish it from a placental abruption. So the ladies with a placental abruption will often present hemodynamically unstable, in a lot of pain, with or without vaginal bleeding. So these patients will present with intermittent painless vaginal bleeding, and often it will come and go. So complications, the placenta being in the lower segment does obstruct the engagement of the head, and often with a confirmed placenta praevia, these like mothers will have a cesarean section. Hemorrhage can be severe and may continue during and after delivery, as the lower segment of the uterus isn't able to contract as well as the upper segment can, so can lead to things like postpartum hemorrhage. But often, you know, once it's picked up on ultrasound, these are managed with C-sections and tend to be less complicated deliveries than some of the other causes of an antepartum hemorrhage. Okay, so then I've not really got much information on the slide about this. So this is vasoprevia. I don't think it's that important to know a lot about. I think it's just important to know about. So this happens when the fetal blood vessels run in front of the presenting part, and the vessels will rupture when the membranes rupture. So if you can see on the image, the umbilical cord goes from baby into the membranes and then into the placenta. So what will happen, instead of it going directly into the placenta, so what will happen is when the membranes rupture, that vessel will rupture. And this will cause painless, massive hemorrhage. And often, unfortunately, C-section just isn't quick enough to save the fetus because the hemorrhage is really significant. But this is really quite rare and isn't something that's seen as common. Okay, so then moving on to uterine rupture. So uterine rupture is when the muscular wall of the uterus tears during pregnancy, and there are two main types. So this is now moving on from antepartum hemorrhage. This is now moving on to some of the other obstetric emergencies. So there's two main types. So there's incomplete, which is where the peritoneum overlying the uterus is intact, and therefore the uterine contents remain within the uterus. And there's complete, and this is where the peritoneum is also torn and the uterine contents escape into the peritoneal cavity. So the main risk factor for this that's really important to understand is having a previous C-section scar, but a classical one, so the vertical incision. Having had any previous uterine surgery, anything that's disrupted the uterus previously will obviously cause a weaker area, and that could lead to the possibility of a uterine rupture. Induction of labour, so any woman that has her labour induced. And then obstruction of labour, and this is a lot more common in developing countries, and this is something that you should think about. And this is often when women are malnourished when they're younger. They don't develop proper hip bones, and so they have issues with their birth tract and the baby not being able to fit through them and descend as it normally would. But also, unfortunately, we do have to think about things such as FGM and how that can have an effect and cause uterine ruptures. So clinical features: sudden severe abdominal pain, vaginal bleeding, regression of the presenting part, and hypovolemic shock. The important thing to remember about this with uterine rupture is the sudden severe pain will persist between contractions. So the pain will be constant. It won't come and go like a contraction will. It will be persistent. And then management, again, ACE assessment, resuscitate the mother. The fetus will be delivered by C-section because the uterus is already ruptured. And the uterus will either be repaired or removed depending on the degree of rupture, and also dependent on the mother's wishes and request. If it's a young mum and she really wants more babies, then they might be more willing to have a go at repairing it. But if it's a lady who's content that she's finished her family, she might be wanting to have the uterus removed, as that will ultimately lead to better outcomes. And the Royal College of Obs and Gynae guidance says the decision to incision interval should be less than 30 minutes. And then with uterine rupture and placental abruption, the way to differentiate them is by manual examination. So you need to examine these women bimanually. If they have going back to this buzzword, a woody tense uterus, that is placental abruption. If they don't, and the uterus doesn't feel hard or tense, then you've got to think of uterine rupture. And I have put a little picture up to try and, because I think it illustrates it really well, but it's not a particularly nice picture, so I won't leave it up for too long. But that's the type of tear that you'll often get in the uterine wall. Okay. So another MCQ, hopefully won't reveal the answer this time. So a bit of a simpler one. Which of the following obstetric emergencies, if not dealt with effectively, most commonly leads to the complication of Erb's palsy in the fetus? So I'll give you all a little bit of time to answer. Okay, so I'm going to end it there because the majority of people have voted. I'll see if I can show you the poll answers. Okay, so as you can see, the majority of people have gone for shoulder dystocia, and that is the correct answer. So I'll talk a little bit about shoulder dystocia now and why this happens. So shoulder dystocia, so this is an obstetric emergency that happens during labour. It's defined as vaginal cephalic delivery that requires additional obstetric manoeuvres to deliver the fetus after the head has delivered and gentle traction has been unsuccessful in delivering the shoulders. So it occurs in around 1 in 200 deliveries and really does require urgent senior help. So risk factors pretty much are all around the large baby, so macrosomia. So poorly controlled gestational diabetes in the lady, and also insulin-dependent diabetes, which suggests that it's more severe or poorly controlled. Maternal obesity and having had previous babies with shoulder dystocia. So complications, delay in delivery combined with many unsuccessful attempts will cause brain injury, and unfortunately there is a risk of death in these fetuses as well. So excessive traction on the neck will damage the brachial plexus, and you can kind of see in this picture here the damage that's happened to the brachial plexus, and it results in Erb's palsy, which is this different posturing of the hand, and it can be permanent. In about 10% of cases, the brachial plexus injury won't solve itself, and it will be permanent. These children often require a lot of physiotherapy input to help renew the function and the sensation in their arms. Okay, so in terms of the management, this is really important to know and to understand. So there's like a little acronym called HELLP. So the H is call for help. So shoulder dystocia should be managed by the most senior person available on shift. So in most places that would be a consultant. If you're in a room and you're struggling to deliver the shoulders, then it's really important to pull the emergency buzzer, and people will come running, but that's exactly what you need because you need that senior help. So the E is evaluate for episiotomy. So you need to think, is a simple episiotomy going to help? Is it going to help deliver the shoulder, but also it will aid in your further management? So L is for legs. So you want to think about the Muck-Roberts manoeuvre. So this is lying the lady on her back and bringing her knees up to her chest. And this is because if you can help just by something as simple as changing the position, then you really need to. So P, suprapubic pressure. So putting pressure suprapubically will help almost not force, but will help that shoulder come out. E stands for enter. So rotational manoeuvres. This is something that you really want your consultant to be doing at this point. You know, if you're a junior or even a junior reg, you shouldn't really be doing this. So you want to enter with your hand, and you're going to try and rotate the shoulder 180 degrees, and that's to try and narrow the width that has to pass through the birth canal. R is remove the posterior arm. Again, this is a tactic to try and reduce the width that's got to pass through the birth canal. And then R, finally, roll the patient to hands and knees. This is kind of like a final attempt at getting this fetus out safely. And by this point, the majority will have been delivered successfully. Often the rotational manoeuvres and removing the posterior arm are enough for fetal delivery. So the next obstetric emergency I'm going to talk about is umbilical cord prolapse. So this is defined as the descent of the umbilical cord through the cervix alongside or past the presenting part in the presence of ruptured membranes. So cord prolapse should be suspected where there's an abnormal fetal heart rate pattern, especially if the changes commence soon after membrane rupture, whether that be spontaneous or artificial. So there's often not a classical presentation of this. It's often something that should be ruled out whenever there are signs of fetal distress. So the risk factors include things like polyhydramnios, multiparity, and multiple pregnancy, any fetal congenital abnormalities, low birth weight, or actually large balloon catheter induction of labour can often cause a umbilical cord prolapse. So diagnosis, vaginal exam is the most important aspect of diagnosis. This is really the only way you're going to know if there's a cord prolapse. And sometimes this is done, like I said, for abnormal fetal heart rate patterns or if there's any signs of initial fetal distress, but also it can be detected just on the routine vaginal examinations that women have every couple of hours during labour. And then management, so to prevent vasospasm, there should be minimal handling of the loops of the cord lying outside the vagina. So that's because if you start handling them, the vessels will constrict and it will reduce the blood flow to the fetus. The presenting part of the fetus should be elevated either manually or you can fill the urinary bladder. So if you fill the urinary bladder, it will push the presenting part back higher. Women can adopt a knee to chest position, but emergency C-section will be needed. And as you can see on the picture, this just shows the normal position of the umbilical cord and then what we mean by a cord prolapse. So that's when the cord just literally comes out of the cervical os and sits in the vagina. So moving on now to amniotic fluid embolism. So this is a rare cause of maternal collapse and is thought to be caused by amniotic fluid entering the maternal circulation. So this causes acute cardiorespiratory compromise and severe DIC. Clinical signs: maternal collapse, shortness of breath, chest pain, lightheadedness, distress and panic. These women present often collapsed, really unwell, without anybody really knowing what's going on. It's often a medical emergency and definitely an obstetric emergency, and you'd assess them using an A to E assessment. They will need intensive care admission, and that's often for support only. There's no real treatment that we can give. It's got a really poor prognosis, unfortunately. 30% will die in the first hour and only 10% will survive overall. It's often not known what's caused them to collapse, and often amniotic fluid embolism isn't picked up until post-mortem, but it can be suspected. And peri-mortem C-section should be carried out within 5 minutes or as soon as possible after cardiac arrest. And that's actually, as much as for the fetus, that's actually to try and help the efforts at resuscitating this lady from cardiac arrest. But often it's not successful. And like I said, it's really difficult to diagnose. And so typically it's not diagnosed till post-mortem. So we've got another MCQ and then we'll be moving on to postpartum hemorrhage, which I think is the last topic I'll be covering. So what is the most common cause of primary postpartum hemorrhage in the UK? There should be a poll that's gone up for you all. So the majority of people have voted, so I'm going to end the poll there, and I'll share the results with you all. Okay, so about 67% of you went for uterine atony. A few people have gone for some of the other answers: perineal tear, placenta accreta, and thrombus. So the correct answer is uterine atony. So we'll talk about postpartum hemorrhages and the causes of that now. So postpartum hemorrhage can be split into like primary and secondary. So primary postpartum hemorrhage is the loss of 500 mils or more of blood from the genital tract within 24 hours of the birth of a baby. And it can be minor, so 500 to 1,000 mil, or major, which is more than 1,000 mil. And then secondary PPH is defined as an abnormal or excessive bleeding from the birth canal between 24 and 12 weeks postnatally. So I'm just going to really focus on primary postpartum hemorrhage, and that's because that's probably the most common, or one of the most common, obstetric emergencies that you'll come across. So the causes can be attributed to the 4 T's. So that's tone, so uterine atony, and this is actually the most common cause of postpartum hemorrhage. And the risk factors for this is it being a multiple pregnancy. So the more the uterus is stretched, the more it has to contract to be able to stop the bleeding post-delivery. Any woman who's had a previous postpartum hemorrhage probably is due to uterine atony, and so she's at risk of that happening again. Again, things like fetal macrosomia. So the more the uterus is stretched, the more it's got to coil again. Failure to progress in the second stage, prolonged third stage, and general anaesthesia. So the second T is trauma, so episiotomy and perineal laceration. So these can cause postpartum hemorrhages, and these actually occur very commonly, as in like episiotomy and perineal lacerations, and any type of tears. However, they often don't bleed enough to be classed as a postpartum hemorrhage, so these often don't bleed more than 500 mils. Tissue, so placenta accreta, which I'm going to cover slightly at the end. And then thrombin, so pre-eclampsia. Like I said, these people are prothrombotic and will need to be treated with subcut heparin. Okay. So in terms of prevention of postpartum hemorrhage, so there's active management of the third stage of labour, and this routinely reduces postpartum hemorrhage risk by 60%. So this is for anybody. So any woman delivering vaginally should be administered 5 to 10 units of IM oxytocin, just prophylactically. And any woman delivering by C-section should be administered 5 units of IV oxytocin. So in terms of management, so the Royal College of Obs and Gynae guidance says that clinicians should be prepared to use a combination of pharmacological, mechanical and surgical methods to arrest PPH. So again, you will resuscitate the patient with an A-to-E approach. Then in terms of bimanual compression, as you can see in part A of the picture, you can palpate the uterine fundus and rub it to stimulate contractions and ensure the bladder is empty. So you can insert a Foley catheter just into the bladder, and then this is called rubbing up the fundus, and that will often help it compress and stop the bleeding. In terms of pharmacological measures, oxytocin, 5 units by slow IV injection, and you can give many repeat doses of this. It's not just a one-off. There's ergotamine, 0.5 ml by slow IV injection, but this is contraindicated in women with hypertension. And then there's other pharmacological options such as carboprost and misoprostol. But most often oxytocin is given. Then surgical measures. So you want to start off with something that's going to preserve the uterus. So intrauterine balloon tamponade. So that's what's in picture B. And then if things like that don't work, you can move on to a brace suture. And again, that's sparing the uterus. If none of these work, you need to do a hysterectomy because that's the only way that you're going to ultimately stop the bleeding. Okay, and then finally, this is just the last slide, just a little bit about placenta accreta. So this occurs when all or part of the chorionic villi attach abnormally to the myometrium. And there are three main types. So there's placenta accreta, where the placenta attaches strongly to the myometrium, but it doesn't penetrate it. And this is 75% of cases. And placenta accreta is one of the causes of tissue retention that causes PPH. So there's then placenta increta, and that occurs when the placenta penetrates the myometrium. And then finally, the most severe is placenta percreta, and this is when the placenta penetrates the entire myometrium to the uterine serosa, and it can lead to the placenta attaching to other organs in that area, such as the rectum or the bladder. And as you can see, that the one that's least severe is the more common of them, and the more severe it gets, the less of it you see. Risk factors: placenta praevia is a major risk factor for this. Especially in the presence of a uterine scar, increased maternal age, prior uterine surgery, and this thing called Asherman's syndrome, which is where women get uterus, and this is caused by any prior interventions, often D&C from miscarriage. So management: if diagnosis is made before birth, which it can be with ultrasound, then these will have a planned C-section plus or minus abdominal hysterectomy. And that will be dependent on the severity. So if it's a known placenta percreta, these ladies will often be consented for C-section with abdominal hysterectomy. If the woman wants future pregnancies, uterine sparing surgery can be considered, but it's not as successful. And often women who opt for uterine sparing surgery will then end up having to have a hysterectomy as an emergency anyway, and they do have a higher risk of complications. Okay, so that's me done. I know I've spoken about a lot, but you'll get the slides, I think, if you fill out the feedback, and also the session's being recorded. So if there's any bits you want to go back on or I spoke too quickly through, then you can go back and watch the recording or just look through the slides in your own time. In terms of resources, I use the Royal College of Obs and Gynae green top guidelines. These are like almost like your NICE guidelines, but for Obs and Gynae. They're really, really useful. And they talk through the evidence base of what they're saying. So they give it like an evidence rating. So they say how strong the evidence is and why they recommend that. So it's really good to try and get your head around why they do the management and why they suggest what they do. Some of the other things, Obs and Gynae book, the Lawrence MP and Tim Child book, I think is really good, and also the 10 Teachers one. And then I really like BMJ Best Practice. I think it's a really good tool, so I use that quite a lot. And then also some of the websites like Almost a Doctor and Teach Me Obs and Gynae. But yeah, that's me all done.